evening, good afternoon, good morning from who is from wherever. So great to do a presentation from my room instead of packing my bags and traveling all over the country. I'm going to be talking about neuropathic pain and dysautonomia, and it's kind of a lengthy talk. I've tried to shorten it as much as I can, just so I stay on time. Give me 1 second, my timer. So we are going to talk about neuropathic pain and dysautonomia, and it's a really long subject. I've cut it down to the basic stuff, like take-home messages. This is a standard disclosure and disclaimer. You guys can read it anytime you want. It means that I'm not paying someone or no one's paying me, blah, blah, blah. I am a pain medicine specialist, and my special interest is in complex pain conditions in both adults and children. Did my training and fellowship in Boston at Harvard, and then now I work as a assistant professor at Brown Medical School in Rhode Island, USA. So let's start with types of pain. There are essentially two types of pain. There's the nerve pain, which is known as neuropathic pain. That's because the nerve is damaged. There is structural pain when something is broken, like arthritis of a joint or dislocating a joint. Now, most pain conditions are a mix of both, and they're both structural and nerve pain, and that's the most common type. Quick question, can you see me?
Yes, we can see you.
Oh, okay, I can see myself. Okay, so I can move my hands around to demonstrate. Is that okay?
Yes, you may.
All right, so we have two kinds of pains. We have neuropathic pain, and then we have the structural pain. Most pains are both, but it all varies. For example, somebody with neuropathic pain has lots of neuropathic pain, but some structural pain. Vice versa, somebody with, say, a dislocated joint has lots of structural pain, also known as nociceptive pain, but some neuropathic pain, and that's how the difference is. So, but the subject for today's discussion is neuropathic pain. I'm just going to briefly talk about the nervous system for a second. The nervous system is made up of three parts: the brain and the spinal cord, which is known as the central nervous system. And the reason I need you to know this is we'll talk about it a little bit later. And then you have the peripheral nerves. That's the nerves everywhere else in the body except the brain and the spinal cord. And then the third type are the autonomic nervous systems, which is nerves that control automatic functions. Basically, God did not trust us to handle this stuff, like focusing, breathing, movement of the intestines. This is all under automatic control, and so it's called autonomic nervous system, and we'll touch about that. Neuropathy can affect any of the above. It can affect the central nervous system, it can affect the peripheral nerves, it can affect the autonomic nervous system. Neuropathic pain is more structural pain. It's not inflammatory pain. So it's most types of neuropathic pain are structural. That means there's an actual damage to the nerve. And that of course causes some inflammation. But the problem, that's why it's so difficult to treat neuropathic pain, is because there's structural damage to it, and there's an ongoing structural damage. So the important part that I want to talk about is how to diagnose it and how do you treat each of these conditions. So like I said, most pains are both mixed structural and neuropathic pain. Unfortunately, structural pain can trigger neuropathic pain. And let me give you an example. Say, for example, if you dislocate a joint, that's structural pain. But dislocating the joint can affect the nerve that crosses over the joint or is in some way related to the joint, which would then cause the nerve to be damaged. So now you have both structural and neuropathic pain. And in that case, of course, the treatment would lie in stabilizing the joint. That would then fix the structural pain and then eventually fix the neuropathic pain. And so it can also be as an overstretching of the nerves, as is seen often in patients with Ehlers-Danlos syndromes. And then there's compression of nerve fibers in different conditions. One of the big topics in dysautonomia is small fiber neuropathy. It's easy to diagnose, everybody knows about it, but treating is a nightmare. So let's talk about small fiber neuropathy. Just so you know what a small fiber neuropathy means is that the nerves, imagine the imagine the trunk of a tree and its roots. So the trunk in your case is the spinal cord, the brain and the spinal cord. And then as these nerves exit the spine and then they move out to your limbs, so as they keep moving down to your fingers or down to your toes, they become thinner and thinner and thinner, and eventually become really very thin by the time they reach your toes. And that's where that's what's called as small fibers over there. So these nerve fibers, by the time they reach the tip of your fingers and your toes, they're called small fibers. And if there's anything that's going to cause any damage for any reason, it's the smallest nerves that are going to be damaged first, because these are the least protected and they're also the smallest. They're also the furthest away from the spine, so usually in the feet and hands. And a classical presentation of small fiber neuropathy is a stocking and glove distribution. So you can see over here how it's in a very stocking distribution. It usually starts in the feet first, because that's the furthest. And then when it becomes a little more severe, it can show up in the hands. And so a classical distribution is stocking and glove distribution. These patients present with very specific symptoms, including temperature perception and touch. And I'll get into that a little bit more. So among the small nerves that you find in your hands and feet are two kinds. There are small nerves that carry sensations from your feet and hands. And then you have the autonomic nerves, which control all the automatic functions. Either one of these could be affected or both of them can be affected. Small fiber neuropathy is when so in autonomic neuropathy, that's a whole different animal. And that's one of the things that's the main subject that's being discussed at the Dysautonomia conference this time, is about how autonomic nerves start to misbehave. These are very, very, very small nerves and they can easily get damaged. It's one of the causes of dysautonomia, but not the only cause of dysautonomia. So what do patients with small fiber neuropathy present with? They present with burning feet. It's a constant burning feet. They have pain to touch, or they have a weird sensation to touch. Their feet feel like wood. And sometimes it also feels like they're walking on pebbles. They have decreased thermal sensation, which means they can't detect the difference between cold and hot. They have decreased pinprick sensation. They have varying degrees of numbness. Pain is, of course, the big one here. They may have something called dysesthesia, which is like a creepy, crawly, weird sensation they have. So patients can have any of these or all of these. But the point to note over here on this slide is muscle strength is not affected. Small fiber neuropathy does not affect muscles and reflexes. So this is because oftentimes patients get worried because they're getting all this pain in their feet. They think that they're going to get paralyzed. That's not going to happen, not from the small fiber neuropathy at least. In the autonomic nervous system, this is the automatic nervous system, and it controls all the automatic functions in the body, which includes movement of the intestines, breathing, heart rate, sweating, blood pressure. And none of these are under our control. And obviously, when patients have dysautonomia or dysfunction of their autonomic nervous system, all of these or some of these can be affected, as everyone knows on this group. Patients with autonomic neuropathy may present with dry mouth, dry eyes. There's slowing down the intestines, known as gastric paresis or small intestinal dysmotility. They can have diarrhea or constipation, or both diarrhea and constipation alternating. They can have nausea, dizziness, and fainting. Because their heart rate is so high and their autonomic nervous system is so revved up, they have this feeling of anxiety. It's not true anxiety, it's a feeling of anxiety. They have increased sweating, which usually happens at night especially, or with eating, and they have increased urinary frequency. So there's a ton of reasons why people have small fiber neuropathy, and at some points I'll talk to you about all of those, but can't go into the details because those are all different subjects and different conferences on their own. But one of the things that researchers have noticed is glucose dysmetabolism. People who have that means if they're not metabolizing their glucose properly, are very, very prone to developing small fiber neuropathy. And I don't just mean diabetes mellitus, I mean impaired glucose tolerance. And so somebody with small fiber neuropathy, that would be the first thing to look for is, how is your glucose metabolism? Do you have any impaired glucose tolerance? You may not have diabetes. So even a mild abnormality in the glucose metabolism puts patients at risk for small fiber neuropathy. And of course, autoimmune dysfunction, your own immune system goes rogue and it's working against you. And that then triggers damage to the autonomic nerves over here. So having said that, the most common cause of small fiber neuropathy is actually unknown, what we call in medical terms, idiopathic. Diabetes is up there. High cholesterol is very much up there. Autoimmune conditions as triggered by viral infections. You just heard about COVID-19, and then Sjogren's syndrome. And there are a bunch of other autoimmune conditions, named and unnamed. So there's a lot of autoimmune conditions we don't even know about. We don't even have a name for it. Will usually start after some sort of a minor viral infection, and then things go downhill. Alcohol. Now, when I say alcohol, I don't mean the occasional sip or the occasional drink. I mean, really lots of alcohol every day. Medications, there are some medications that can cause small fiber neuropathy. These are usually medicines used for treatment of cancer. And nutritional deficiency. This is not something you should take lightly, nutritional deficiency, because that's something that we see a lot in patients with small fiber neuropathy, patients with small mast cell activation syndrome, Ehlers-Danlos syndromes, and other conditions. Nutritional deficiency is a biggie because they all have, or most of them will have, some sort of a GI issue. So how do you diagnose small fiber neuropathy? It's not that hard. The most important part is clinical history and examination. And I just showed you what the clinician should be looking for. Where's the pain? Is it in a glove and stocking distribution? Your feet feel like wood, there's pain over there. And the whole examination. This is extremely important. Skin biopsy is a gold standard over here. So they do a little, it's like a little needle punch. They take a little bit of skin and look at the number of fibers. There's a test called the QSAW test. If you like it, I put down the whole name over there. But essentially, they look at how you sweat. And that gives them an idea of how the autonomic nervous system is working. An EMG is not a good test. It's obviously done to rule out if there's anything else, but it is normal in small fiber neuropathy. It does not, EMG is only for large fibers and not for small fibers. So how do you manage small fiber neuropathy? I've put in a section on management of small fiber neuropathy, which I'll go through, but over the presentation, I'll be talking about different treatments for different conditions, and they all apply to small fiber neuropathy. So, the treatment for pain, there's only one principle behind treating pain. It's to treat what's broken. That's it. There's no other treatment for it. If you have a dislocated joint, unless you put that joint back in place, the pain is still going to be there. It's like driving a car with a wobbly wheel. No matter how fast you drive, the wheel is still going to wobble unless you actually go in there and tighten the nut that holds the wheel. I'm not talking about the driver, I'm talking about the nuts that hold the wheel. Unless you don't tighten that nut, you're not going to get any progress. So oftentimes I get this bizarre thing about, all right, just work through the pain or just live with it. That's not the way to go through with it. You've got to find what's broken, what's causing the pain, what's squeaking, fix that, and then move on. So in terms of small fiber neuropathy, is it your glucose intolerance? Is it your cholesterol? Is it your autoimmune dysfunction? Is it nutrition? Is it one of those viral autoimmune dysfunctions? Let's look at all those before we start to think about treatment of pain. So that would be, so treating what's broken is is the plan A. That's the number one step. But the second step is, meanwhile, while you're working on that, there are some treatments that patients can do. One of the top favorites of doctors is amitriptyline or nortriptyline. These are very, very old drugs, initially approved for treatment of depression. They also help with sleep. I think it's a very good choice. Excuse me. Amitriptyline or nortriptyline. Gabapentin is a useless drug. I won't waste my time on it. Duloxetine, or marketed as Cymbalta. Unfortunately, the principle behind duloxetine and milnacipran, the Savella, these are both the same, and they're both in the same family. The difference being that Savella does 3 times better job than duloxetine does. And problem with Cymbalta or duloxetine is that it has a lot of unacceptable side effects, and it's a nightmare to come off it. Savella, which hasn't really, for some reason, has not become very popular. And I think it's because of the company not publicizing it a lot. It's been approved for treatment of fibromyalgia. Personally, I think Savella or milnacipran is a better choice. Opioids, despite all the negative press about opioids, this is one place where opioids can be tried. It's not the best choice because it doesn't really treat the problem, but yes, it can. If it makes you functional, absolutely try it. Among the opioids, tramadol and tapentadol, which is marketed as Nucynta, can be helpful just based on the way they work. These are 2 so-called opioids that have a very different mechanism of action, and it's worth trying. Topical creams, there's a slew of topical creams out there. Doctors have been putting things together, and compounding pharmacies have been cooking them up. It's certainly worth a try. They won't do any harm, low side effect. There's a cream that you can buy. It's actually on Amazon. You can buy it. It's called Tethered cream. It was made by Dr. Ted Price. It's the way it works is a very, very neat mechanism. Definitely worth trying it. It's slightly on the expensive side, but definitely worth a try. Tethered cream. My all-time favorite is low-dose naltrexone, and I'll get into it a little bit more later on. But the usual dose of low-dose naltrexone is 1.5 to 4.5 milligrams. You can go a little higher also, but it has to be once a day. Remember that. Definitely once a day, not more than that. It helps with pain and fatigue. We'll talk about it more later on. There was some discussion with the mast cell activation syndrome and small fiber neuropathy. Mast cell activation syndrome, mast cells are normally found in the body. They're part of your immune mechanism. So if you have some sort of a trigger, your immune system throws an alarm, and these mast cells go rushing there, and they start to release chemicals. Among the chemicals they release are histamine, tryptase, cytokines. But the 2 interesting ones that they release are called calcitonin-related gene peptide, or CGRP, and substance P. I'll get back to CGRP later on because that is a really great thing to understand. So these chemicals then cause inflammation of the nerves, and that's how patients with mast cell activation syndrome have pain. Essentially, it causes inflammation of almost any tissue in the body, and if the tissue is already damaged, then it causes even more inflammation. So if your right wrist hurts before you have a mast cell activation syndrome, then that right wrist now starts to hurt even more. So essentially, it's like having flu all the time. Flu is a kind of a mast cell activation syndrome. So the easiest way to explain to someone what mast cell activation syndrome is, it's like I have flu all the time. There are 3 parts of the treatment. It's a really complex treatment, but I've cut it down because of the time. The first part is, I should say plan A is antihistamines. Famotidine, which is Pepcid. Unfortunately, most of the Pepcid that we are getting in the United States now is fake. And so this effectiveness is not that good at all. We have wound up doubling the dose just because we think that there's not enough famotidine in the pills. Among the antihistamines, so famotidine is a histamine 2 blocker. You also need a histamine 1 blocker, which is a common cold medicine like Benadryl, Zyrtec, Claritin. My choice is clemastine. Clemastine is a very, very old antihistamine. It also helps with pain, and that's my choice of drug to go to. It's supposed to be over the counter, but it's easier to get it if you have a prescription. The second part of the treatment is to now stabilize these mast cells. Remember I told you these mast cells are misbehaving. There are 3 drugs in this class. One is called ketotifen, which is a prescription drug. Cromolyn, which comes in all kinds of forms, from putting it in your nose to your eyes to inhaling it to drinking it. And then the third one is quercetin, which you can actually buy it over the counter. Quercetin, 500 milligrams twice a day. It's made out of pineapple, so I call it a pineapple in a pill. So these 3 drugs are mast cell stabilizers. So merely taking antihistamines is not the answer, because we need to stop the problem. The problem is your mast cells are misbehaving, so we need to stabilize these mast cells. And these are the 3 drugs to use for that. The third part, which is actually very difficult, is to find what's triggering these mast cells. And the way I look at it is either you're eating it or breathing it. Is there something in the food that you eat that's triggering these mast cells? Or is there something in the air that you're breathing that's triggering it? Foods like, the foods that we eat in the United States is not it's not real food. Even the rice is not real over here. So the foods have started to really affect our systems. Look at gluten, look at gluten-free foods, avoid seasonings. Sugars can do it, dairy can do it, beef can do it. Well, it depends. If the cow eats the gluten grain, and then you eat the cow, and of course you get the gluten, so it causes, that's the other problem. Quality of air that you breathe is, look for mold in the house. Is there mold? Is there stuff in the carpeting? Things like that can trigger mast cell activation syndrome. Let's talk about headaches and dysautonomia. Headaches are generally very common, whether you have dysautonomia or not, but most patients with dysautonomia do have headaches. The good thing about migraines is that there's a new class of drugs called CGRP antagonists. Remember I showed you when I was talking about MCAS about the CGRP antagonists. So now we have this new class of drugs called CGRP antagonists. They block the effect of CGRP. Right now we have 2 kinds. One is for chronic migraines. They are sold in the market as Emgality, Aimovig, and Ajovy. And then these 3 are injections. Then you have the pill form for the acute migraine, which is Nurtec, ODT, and Ubrelvy. They both work fantastically. And here's the strange thing. They have almost no side effects. This is not just me saying it. This is the official FDA version. The only side effect from Emgality, Aimovig, and Ajovy is the little pinprick that you get from the needle. So, so far I haven't seen any side effects, but these are the drugs that are out there. I am a little optimistic that these drugs will eventually start to help with other neuropathic pain conditions, because CGRP is released in other neuropathic pain conditions. But what about the regular headaches, not the migraine headaches that you see in dysautonomia? Obviously, correct your salt and fluid intake, compression clothing. For the acute headache that you get, one of the things I like is sequential compression boots. These are, I don't know if you have ever been to, when you go to the hospital and you have surgery, they put these boots that squeeze your legs intermittently. They're called sequential compression boots, or SCDs. You can actually buy them, and they're relatively inexpensive. The brand that I looked at was Fit King on Amazon, of course, everything's on Amazon. They sequentially push the blood up your leg. They're particularly useful if you're having a really bad potsy headache or you're having a bad potsy day. The reason I'm saying that is because with the SCDs on, you can't walk around there. But these are something useful to look at. It's a very non-chemical and a non-medical way to treat it. Um, Briefly want to touch on Cleary malformation. I know a lot of the patients with dysautonomia have EDS, and Cleary malformation is fairly common in them. On the left, you can see this is the normal brain. You see this cabbage-like thing, it's called the cerebellum. On the right, you can see the cerebellum starting to poke through the hole at the bottom of the skull, and that's called Cleary malformation. These patients present with pain. They present with neck pain, balance problems, weakness. They have tingling in their hands and feet, dizziness, vision problems, and so on. But the most important one I wanted to point out was headaches made worse by coughing or straining. So so somebody presenting with, let's say, tingling in their arms and legs and also have headaches, think of Cleary malformation and then say like, okay, your headaches get worse when you cough? Or do you have ringing in your ears? Do you have difficulty swallowing? Do you have balance problems? And that should trigger thoughts of Cleary malformation. The other reason patients, especially patients with joint hypermobility and Ehlers-Danlos syndromes, is craniocervical instability. Essentially, the neck joints are loose. They're stabilized by ligaments. These ligaments are elastic, so the joints aren't that holding you well. So they cause compression of the nerves and the spinal cord. These patients also present with neck pain, headaches, dizziness, ringing in the ears, poor balance, and they do present with symptoms of POTS. And this is another reason to look at for patients with POTS that we look for is, okay, if somebody comes in with POTS to my office, I look, among the other causes, I will look for craniocervical instability if that is one of the contributing factors. It's a very easy test you can do in the office itself. Or patients, when they wear a neck collar, they notice that their POTS symptoms improve almost immediately. Their brain fog lifts off, things look clearer, and of course, it may help their pain. Management of craniocervical instability, the initial part is, of course, strengthening your neck muscles. And then I recommend a hard cervical collar. And of course, if it's very severe, then it's a surgical fusion. Muscle spasms and muscle pain. This has been a big deal and has been very ignored. So I wanted to show you something here interesting. I don't know if you can see my cursor. This is the brain, and you can see this little thing in the middle. The blue thing is called the basal ganglia, which are a bunch of parts in the brain. What happens is that in patients with chronic pain conditions, so this is the part of the brain that is concerned with controlling movement, cognition, emotion, and body perception. And the chemical that the neurotransmitter, the messenger that it uses is dopamine. And it has been shown that in patients with neuropathic pain, there's reduced dopamine in the brain. So here's a drug called levodopa, marketed as Sinemet. This drug is as old as the ages. Sinemet was initially approved for the treatment of Parkinson's. What it does is it increases your dopamine levels and helps reduce muscle spasms. So and personally, from my experience, I can tell you that it does make a significant difference to patients with muscle spasms and muscle pain, trying a small dose of Sinemet, or also known as levodopa. Magnesium is very, very helpful. Unfortunately, our supply of magnesium comes from green leafy vegetables. The green leafy vegetables that we eat now are not grown in proper soil. Most of them are grown in greenhouses. They don't have enough magnesium. So a lot of us are magnesium deficient, and it can help with muscle pain. It can be taken by mouth or topically. The problem with taking it by mouth is that you run the risk of causing diarrhea. So one of the things you can try is called Epsom salt bath. 2 large cups of Epsom salt in a bathtub. It contains magnesium, and you soak yourself in it. That helps well. If you can't do an Epsom salt bath, you can buy magnesium topical. It's, again, Amazon has the magnesium creams, lotions, oils. It does not have the same GI side effects, but it does get absorbed through the skin. So if you're having a crampy muscle day or your muscles are really aching, putting some magnesium on it does make a difference. Tethered cord syndrome, again, this is a common problem in patients with joint hypermobility, but it's also present in patients without joint hypermobility. In this one, what happens is, if you look on the left, the spinal cord ends at L1. So this is a cross section of the spine, and this is the spine, and it ends at L1. That's where it normally ends. After that, it becomes a thread. It's not a nerve, it becomes a thread. It's actually a useless thread called phylum, and then that just kind of hangs over there. So this phylum just hangs out in your spine, does nothing. It's the reason it hangs loosely is because as kids grow taller, as the entire spinal cord and the brain moves up with them. In some cases, this phylum can actually be attached to the bottom of the spine, to the tailbone. And once that happens, it tugs on the spinal cord. When it tugs with the spinal cord, it pulls down. So now you can see on the left, it was at L1, and on the right, where it's being pulled down, it's now at L3. The problem with this tugging is that it pulls on the nerves that come out from the spine, and it can cause symptoms of neuropathic pain. So what do they look like? These patients present with back pain, not explained by any other reason. They have pain and weakness in their legs. Their weakness, the weakness in their legs gets worse as they walk. They also have spasms in their gastroc muscles and in their calf muscles, and their bladder function is affected. It's called neurogenic bladder. And these are some of the features that we look at: unexplained low back pain, pain in their legs. It's kind of a diffuse pain, and your bladder is affected. Belly pain, abdominal pain. So remember, movement of the intestines is controlled by autonomic nerves, and these nerves control all automatic functions. So once patients develop autonomic neuropathy, it can cause slowing down of the intestines. Now, just to be clear, slowing down the intestines can also be from a bunch of other conditions. For example, mast cell activation syndrome can do it. POTS can do it also. So I don't want people to assume that anytime they develop gastroparesis or slowing down of their intestines is because they have autonomic neuropathy. So these patients present with early fullness, belly distension after taking a small amount of food, nausea, or they can have diarrhea or constipation or both. I'm not going to talk too much. I don't have enough time to talk about in detail all of these things, but I like to talk about the treatment because I know you guys are all there for the, let's fix it. My go-to drug is a drug called prucalopride. It's marketed abroad in Canada and Europe as Resolor. In the United States, it's marketed as Botegrity. It's just come into the United States about a year ago. But you have to be like the president of the country to get it approved by the insurance company. It's much easier to just buy it from abroad. So Resolor or Botegrity, it's a really good choice. It's worth a try. I haven't seen any great side effects to worry about. The other choice I like is Mastinon or pyridostigmine. Remember we talked about, well, we didn't talk about it. The autonomic nervous system is made up of sympathetic nerves and parasympathetic nerves. And when the autonomic nervous system goes haywire, it's really your autonomic nerves that are going haywire. Mastinon works on the parasympathetic nervous system. And so it dampens down the crazy sympathetic nervous system. Other drugs to try, actually Mastinon is a really good drug to try in patients who have dysautonomia and GI issues. Amitriptyline is a good drug. There's a drug called domperidone. Reglan is another drug. We just recommend it for very short periods of time. Diet changes is also helpful, a gluten-free diet or a low FODMAP diet. These are some of the diets that can be tried. So just to I'm just gonna go through the drugs again. Prucalopride, known as Resolor or Botegrity, is a really good choice. Mastinon or pyridostigmine is also a very good choice. Amitriptyline, domperidone are great choices. Reglan for short periods of time, and of course, diet changes. One of the causes of neuropathic pain in the belly is called median arcuate ligament syndrome. This is a brutal condition. So these patients present with abdominal pain. Like the minute they eat food, they have pain in their stomach. They have nausea, they get tired, they have fatigue after they eat a meal. Their pain in their belly increases with exercise. And certain postures, make their pain worse. For example, standing up makes it worse, lying on their side makes it better. What happens in this condition is that there's a compression of the blood vessel and the nerve that's going to part of the intestine, and is compressed by the median arcuate ligament. So the celiac artery and the celiac plexus or the celiac ganglion gets compressed by the median arcuate ligament, and that causes pain. Obviously, you need to rule out all other conditions. Testing is MRI or ultrasonography or CT scan. The treatment is surgical, where they actually go and release the ligament. And you can see on the left is the normal, this is the ligament, and see how the celiac axis of the celiac artery is not being compressed. And what happens in males is that the celiac artery and the nerve actually travels with the artery that gets compressed by the median arcuate ligament. CRPS, it's a very painful condition. It's called complexional pain syndrome. It usually starts in one limb, but can present in other parts of the body. It's constant pain even at rest, and it has spontaneous intermittent exacerbations. Patients have a temperature difference, they have color difference, there's swelling that comes and goes. They have pain to touch. Their nails grow differently, they're faster or distorted. Hair growth is different. Skin may be thin and shiny, that's usually in the beginning. They have increased sweating. And over here, you can see, obviously the right hand has the CRPS, and you can see the color difference. You can even see the swelling. You can't see the bones and ligaments on the right side, whereas you can see them on the back of the hand on the left side. This is another example. The temperature on the left foot was 88 degrees, right foot was 94 degrees. There's swelling around the ankles, and you can see there's a difference in temperature. This actually happened after a bunion surgery. So what happens in neuropathic pain? What's the problem? Okay, why don't we just go and cut the nerve that's causing the problem? Or why don't we just cut the leg off because it's causing pain? And so the reason we can't do that is because of something called central sensitization. This happens in almost all chronic pain conditions, but applies more in neuropathic pain conditions. What happens is the spinal cord in the brain gets flooded with a barrage of pain signals. And when it gets flooded, then the spinal cord of the brain becomes hypersensitized. Let me show you. Let's say this is the brain and the spinal cord, okay? And these are the nerves that come out from the spinal cord. Let's say this is a nerve that's causing pain. Let's assume this is the nerve that goes to your left foot, and now that's becoming painful. And there's a barrage of pain signals that are going up and down the spinal cord to the brain. So what happens is the entire brain and spinal cord becomes sensitized. When that becomes sensitized, then any other input, so if I touch the right leg, if the pain is on the left leg, if I touch the right leg, or if there's a loud sound or there's a bright light, sometimes this pain can get worse. But essentially, the brain and the spinal cord are so hypersensitized that their pain is magnified, and that's called central sensitization. Some of the drugs we talked about do decrease central sensitization, and that's the key. So how do you manage neuropathic pain? Obviously, we talked about high blood sugar, mast cell activation syndrome, autoimmune dysfunction. Look for structural issues. This is actually extremely common where a nerve may get compressed or stretched. Some of the treatments I'm going to talk to you about is low-dose ketamine infusion, magnesium infusions are topical, alpha-lipoic acid, N-acetylcysteine, they're both over-the-counter. Correcting the vitamin D and calcium levels are extremely important. In fact, the CDC just put out a guideline for treating COVID-19 was to make sure your vitamin D levels were normal. There are other drugs that are used, carbamazepine, phenytoin, lamotrigine, used as drugs. Cannabis is another good drug to try. It may or may not help. It doesn't help everyone. In fact, in some cases, it actually sensitizes you to the pain. But if it does make a difference, then it's a very safe option to try. The only thing I wanted to mention over here is CBD. There's a CBD from hemp that's available at every shop. I would avoid that for many, many reasons. CBD for marijuana is a much better choice. Topical cannabis can help relieve some of the burning pain in small fiber neuropathy. Treatments to avoid steroid injections. There are some exceptions, but generally avoid steroid injections, avoid spinal cord stimulators, peripheral nerve stimulators, and something called capsaicin cream. Capsaicin cream is generally is actually hot chili pepper. The last thing I want to do is put hot chili pepper on a burning foot. I promised you about low dose naltrexone. So LDN increases levels of endorphins, and endorphins are the most powerful pain-killing agents in the world. And so once you increase your endorphin levels, it helps with pain. And so it helps with, using that philosophy, it helps with neuropathic pain, it decreases fatigue. And now we're getting reports that it can help with mast cell activation syndrome also. Start at 1 to 2 milligrams in the morning for 2 weeks, and then go up to 4.5 milligrams per day. You can take it either in the morning or at night. Some of the side effects, they're temporary: headaches, insomnia, or colorful dreams. So if you're into watching movies at night, that would be a good option. But that's the reason why actually I start my patients in the morning, because if they're having any of these, it'll be during the daytime. These side effects usually go away. The key point here is to take it once a day, not more than once a day. That's the way it works. Whether you take 4.5 milligrams or 6 milligrams, it has to be once a day. It may take a few weeks to see a response. The general recommendation is to try it for 6 months. Some patients, especially patients with Ehlers-Danlos syndromes, are super sensitive to drugs. In those cases, you can start them at 0.5 milligrams and go up to 1 milligram and then slowly climb up. It is made by a compounding pharmacy, so you can take out all the garbage that they put in, like coloring agents and preservative agents. And if they don't see a response, then at 4.5 milligrams, it's not unreasonable to go at a higher dose, 6 milligrams to 12 milligrams. I've never had to do that. I've gone up to 6 milligrams, but I know physicians have gone up to 12 milligrams and have seen good results. IVIG, I'm pretty sure somebody's on the conference is talking about that. So patients develop autoantibodies, which means your own immune system is angry at you. It's fighting your own tissue, and it starts to destroy your own tissue. So IVIG is an infusion of good guys, good antibodies to help stabilize the autoimmune system. CGRP antagonists, again, is one of my favorite drugs to try. It's a chemical that CGRP is a chemical produced by painful nerves, nerves that are inflamed. So it makes sense to block CGRP. And we talked about the CGRP antagonists. These are the ones that are approved. Aimovig, I can't even read the generic names. Ajovy, Emgality, these are injectables. Pills are Nurtec and Ubrelvy. I'm sorry, that's wrong. It's not Ubrelvy, it's Ubrelvy. Ketamine is a very powerful agent. I use it in patients with severe neuropathic pain who are not responding to most treatments and are really just in a bad shape. I start on low dose ketamine infusions. Doesn't work well when it's taken orally. It does work well as IV or sublingual or nasal. So the choice is to start at nasal, see how you respond. If you respond to it, then it might make you a good candidate for trying an IV low dose. But remember, ketamine infusions have to be done in conjunction with other therapies like physical therapy, also looking for the root cause of the problem, what's broken. Fortunately, the FDA has recently approved ketamine nasal spray for the treatment of depression, so we have a really good excuse to use it for other conditions. It has to be given in very low doses, not in super high doses. The advantage is that it decreases central sensitization. Remember, we talked about central sensitization. This is one of the drugs. The other drug is LDN, which decreases central sensitization.
Dr. Chopra, I just wanted to remind you of the time. We should probably start moving into Q&A soon.
All right. actually, this is, I think I'm done. This is
Oh,
just ketamine side effects. Most of the side effects of ketamine are temporary and short-lived. There are no long-term side effects that we know of. And that's pretty much it.
Well, thank you. That was a wonderful lecture. You have a lot of questions that I'm going to try to get through. The first one being, is small fiber neuropathy damage ever reversible, specifically in pediatric patients?
Yes, in the early phases, it is. If someone is, if a physician is smart enough to catch it in the early phases, yes. But the problem is oftentimes this patients don't get diagnosed early enough, and by then the nerves are damaged. But in pediatric patients, it's obviously it's not, you know, children don't really develop pain so certainly,
Sure.
and it is reversible. If not, let's say if it's not reversible, at least you're preventing further damage.
Perfect, thank you. Would small fiber neuropathy ever be mistaken or related to restless leg syndrome?
Yes, it can be. Actually, they go side by side in a lot of cases. And I wanted to throw in restless leg syndrome, didn't have the time, but it does cause restless leg syndrome, and it's brutal to have restless leg syndrome with small fiber neuropathy. You remember that drug I talked about, Cinemet or levodopa? That works amazingly well for restless leg syndrome. Half a pill at night and you're good to go.
Perfect, that's great to know. Is fibromyalgia ever considered a small fiber neuropathy?
No, you can't do that because fibromyalgia by itself is a different animal. And, you know, fibromyalgia is a painful body-wide pain associated with fatigue and other things. And so, again, you know, like I just mentioned, fibromyalgia is a presentation. What's causing the fibromyalgia is what we need to look for. And so finding the culprit behind the fibromyalgia, finding what's broken behind it is the key over here. But small fiber neuropathy is not body-wide. It's usually limited to the legs. And in severe cases, it'll be limited to the hands also.
Okay. Does mast cell activation cause small fiber neuropathy, or does it just mimic symptoms?
The answer is yes and no. I'll tell you why. Because mast cell activation syndrome is, as I told you, it's the mast cells misbehaving. And oftentimes we look for, we look for what's causing the mast cell activation syndrome. So is it an autoimmune dysfunction that's causing MCAS? If it's an autoimmune condition that's causing MCAS, then that same autoimmune condition can cause small fiber neuropathy. But MCAS by itself does not, as far as I know, does not cause small fiber neuropathy. It just makes it much more painful, but doesn't cause it.
Okay. Do you recommend that all patients with dysautonomia get tested for neuropathy?
Yes.
Oh my goodness, that's a good question.
Thank you, Lauren.
Yeah, I think they should, because, you know, the key here is to catch it early. And so if you've developed dysautonomia and, you know, you got to look for it and say like, okay, the testing is really simple. It's not a big deal test. And so testing it will give you the answer. And if it's early on, then you can actually work on preventing it. Because once it develops, especially in adults, when it develops, you can't, it's hard to reverse it. You can stop it, but you can't reverse it easily. So yes, the answer is yes.
Wonderful, thank you. You had talked about Tethered cream, and some people had some questions about that. It's sold with and without resveratrol. I probably totally butchered that.
Resveratrol.
Yeah, do you recommend it with or without?
Wait, the main ingredient in Tethered cream is resveratrol.
Oh.
So buy the one with resveratrol. I don't know
Okay.
who's selling without resveratrol, but the main ingredient is resveratrol, and that's the one you need to buy.
Perfect. You had mentioned taking magnesium during your lecture. What's the best magnesium to take, as there's different types?
I know. So my personal preference is something called chelated magnesium. It's let me see if I can write it down on the chat thing. But it's called chelated magnesium. Did you remove my chat thing? CHELATED, chelated magnesium. It's made by a company called Solgar, SOLGAR. It's a very popular brand. It's made in the United States. Everything from the bottle to the drug, everything is made in the US, which makes me feel a little better. And its absorption is much better.
Perfect. In your lecture, you had warned against peripheral nerve stimulators. Does this include the vagus nerve stimulators that go on your ear?
No. The vagus nerve stimulator is different. I'm sorry. Yes, it's worth doing the vagus nerve stimulator. See, the thing is that the autonomic nervous system is made up of the sympathetic nerve and the parasympathetic nerve. Let's call the parasympathetic nerve the vagus nerve. So the sympathetic nerve is misbehaving. And so to bring this guy down, you need to bring up the vagus nerve, because that then stops the sympathetic nerve, or it counteracts the effect of the sympathetic nerve. So it's definitely worth trying the vagal nerve stimulator. Yes.
Okay. Looks like we have time for just a couple more questions, and you did have some questions about medication. Why is gabapentin not very useful, or why do you feel that way?
I knew somebody would ask that. If you're on it and if it's helping, then that's fine. It's not a harmful drug. But there was a study that just came out in the New England Journal of Medicine, and they looked at all the studies ever done on gabapentin, and they found no difference at all. They actually looked at gabapentin and other drugs like gabapentin, like they call them gabapentinoids, and they looked at them and they said there was only a 1-point difference. And they looked at a lot of studies and they said it's not worth it at all, because the side effects are also not that great. And so in my thing is that if a patient is already on gabapentin and it is working, then stay on it, because it doesn't really, it's not harmful, but it's not useful for pain.
Okay. Is LDN okay for a pediatric or young adult patient?
Absolutely, yes. There's actually a whole book on it written by Kathleen McCandless. Kathleen McCandless, I think it's McCandless. She wrote a book on the use of LDN for children for treatment of autism. And so it's definitely, you can use it in kids. I've been using it in kids. It's perfectly fine.
Perfect. Someone had asked for you to repeat the restless drug recommendation that you had said. Sorry. Could you repeat that for us?
I'll show you.
Thank you very much.
Where's the brain? Oh, there it is. See that drug? I don't know if you can see my cursor, but there's a drug called Sinemet, SINEMET. It comes in different strengths. The most common strength is 25/100.
Perfect, thank you. If those of you who had this question, I know it came up a couple times, if you just wanted to take a picture of the screen real quick. Dr. Chopra, that is all the time we have for Q&A.